Hi, my name is Len Bear, also known as P. Sardonicus on Twitter. And this is another installment of Conversations with Experts. Today I'm talking to Dr. Robert Baloh, who is a neurologist at the Department of Neurology at the School of Medicine at UCLA. He co-authored a book with Dr. Bartholomew, a medical psychologist, in which they both proposed a hypothesis that Havana Syndrome is a mass psychogenic illness. How are you, Dr. Baloh?
I'm fine. How are you?
Good, thank you. My first question I asked all my guests, what are you an expert in? And maybe you can give us a background, how you came to this place.
I'm a neurologist, and actually now I'm an Emeritus Professor, just retired in the last year, but I continue to work on research and writing in particular, since that's what I was hoping to have time to do. So I'm a trained neurologist, but my area of expertise is in the vestibular system, which is the balance system of the inner ear. And I've worked on that throughout my entire professional career. I've written many books, and our textbook on the vestibular system is really the main textbook, still it's now in the 4th edition. Essentially understanding the vestibular system, how the balance part of the inner ear works, and how the connections to the brain are made, and how the brain interprets the signals coming from the inner ear balance system.
That's an excellent summary. I know you're well published. I think your latest publication was a review on vestibular migraine. Very thorough. The fact that you're a vestibular specialist in neurology, it's a perfect fit for this conversation. But I would like to start my first question. Well, that was my first question. The second question is, I would like to start where we left off with Dr. Bartholomew. So I had a conversation with Dr. Bartholomew, and I asked him a very specific question. If the ortholytic injury that Dr. Huffer reported was indeed found in Havana Syndrome patients, would that invalidate the mass psychogenic hypothesis? And he agreed. And then he referred me to you as an expert who would further elaborate on this point. So I am all ears. Please explain your position regarding these findings.
Well, first of all, we do not have accurate tests of the otolith organs of the inner ear, accurate clinical tests. They're just not available. I supervised a vestibular testing laboratory for 40 years, and we did not include the tests that were used for otolith function in this study in Miami, simply because they're not reliable. There's a tremendous variability in the normal range. It's very hard to get what would be considered normative data, but many people over the age of 60 don't have a response. So the test itself is not a selective test of the otolith organ. Actually, sound are used as the trigger. Now, we know some of them are sensed by the otolith organ. That's not their, that's the otolith organ normally responds to a different stimulus, but it can be stimulated by certain low frequency sounds. But some of that goes through the auditory system as well. And it's just not a reliable test. The biggest problem is a large normal variability in the tests. And they did not have a control group, a comparable control group, but even what were the normal subjects that were used, as I'm clear, often was done is that simply they use the normal range that the manufacturer provides, which is possibly a few 20-year-olds or 30-year-olds response, but it's just not a reliable test. So if we had a test of otolith function, that is really a big problem in the field. We have pretty decent tests of the semicircular canal function of the inner ear, but unfortunately, we just don't have reliable clinical tests of the otolith organs. These are tests that are used, and we use them, and I discuss them at length in our textbook, in some research programs where you're looking at large groups and looking at average differences between groups. In that situation, it is reasonable because we don't have anything else. But as far as an individual patient to say, yes, you have otolith damage or you don't, and what the degree is, not reliable.
Okay, so are we talking about the same test? Because what Dr. Hoffer specifically said, everybody, of the 25 people who were symptomatic, all of them had at least two ortholytic tests of normal. And he mentions a subjective vertical, subjective vertical, and the two VAMPs, the vestibular evoked potential. One is cervical and one is ocular.
Yes.
Right.
Those are so all those are three now. I was speaking about the two that are objective are the two VAMPs, the vestibular evoked potentials that are sensed by the sternocleidomastoid muscle and the eye muscle. Now, again, even keeping in mind there. So these are not tests of otolith function. They're a test of this otolith muscle reflex.
Correct.
See? So all aspects of that reflex have to be intact for the response to be normal. So if the muscle is not, this is one of the problems, is the muscle, if, for example, the most common one is the VEMP, vestibular hygienic potential, using the sternocleidomastoid muscle. It's hard to get, you have to get a certain tension on it while you're doing the test. If the muscle is not, that's one of the reasons in older people, it often is not, you don't get any response because the muscle is not as, it starts weakening with age. And so it depends on multiple factors in addition to otolith function. But indeed, those two tests are the vestibular evoked potentials are the two you're describing. The subjective vertical is a subjective test. That's a completely different ballpark there. That requires the person's subjective response. So it's not the two vestibular evoked potentials are purely reflex, and there's no subjective response in it. But the subjective vertical is even more variable than those two vestibular evoked potentials. We've had that test for over 100 years, but it's sort of come and gone because it's not there's a tremendous variability, again, in normal subjects' ability to assess the vertical, the subjective vertical.
So can I address that? I mean, the reason it's called subjective, because it's from the patient's perspective, from the
it requires the patient has to make an estimate, and that depends a lot on their if they're anxious or how their ability to make such a perception. And it can be there's a lot of error just in the perception of the vertical, and it varies a great deal from subject to subject. So it certainly is not, I mean, there's general agreement, but it's not a highly reliable. In large groups, it might be of some use, again, in research studies to compare one large group with another, because the variability can be handled to some degree there, but it certainly as an individual test of vestibular function, the subjective vertical is generally known to be not useful at all. It's just not used.
Okay, but in totality with other tests, first of all, the fact that it's called subjective, it's subjective from the patient's perspective, not from the perspective of who is conducting the test, because they are measuring a degree.
Yes,
so that's very good. That part is objective, and the criteria that Dr. Hoffer used are much stricter than a vestibular lab would use. He's basing it on the data of like 300 normal patients, and the statistical method used was so strict. Depending on the method, it would be either in the 5 percentile, or for VAMP test, it would be in the 1 percentile. This is very, very strict criteria. So do you see this kind of abnormality in patients who are just fatigued or just anxious? Because that's how Dr. Hoffer addresses this criticism. I'd like to quote something from his lecture where he addresses that criticism. So Dr. Hoffer says, there has been criticism that some of these tests, some of the people with anxiety or people with other disorders have this abnormality, but not to this degree. That counters that argument. We're talking abnormalities that are extreme. So once again, 5 percentile, 1 percentile. And these are much stricter criteria than a standard vestibular lab uses. So if you see an argument that other people have these abnormalities without the disorders, but not to this extent, not to the extent that we're reporting.
I don't believe it. I mean, I've worked with these tests, and I see normal subjects have zero response. And in terms of the evoked potentials, and a huge variability. And I mean, if he was correct, these tests would be, if they were that reliable, they would be used in every laboratory around the world. They would be generally accepted as I mean, if we had that kind of accuracy of these tests for otolith function, these would be widely accepted. But there is a general acceptance, in my opinion, and what I've seen, is that they aren't. I mean, there's just a tremendous, from no response to a large response in perfectly normal people, and there's just too much variability in normal subjects. And so I don't know. I'd like to see the actual normative data, who's there, who's involved. I mean, publish it. Let us see the. Particularly the normative data, who were these normal subjects? How were they selected? That's what we need to see. I think if you're going to report this kind of thing, you need, I'm not the only one who's been, concerned about the claim, because I know most of the major people that run laboratories around the country and around the world. And they just, they have the same concerns. It's just not, it just doesn't make sense based on our experience with the tests. They're just highly variable in normal subjects. And to say 20 out of 20 subjects had this abnormality, I mean, it's just, it doesn't fit our experience. And I have major questions about it. And then, of course, where does it, so if this is an otolith disorder, Havana Syndrome, how then do we explain all these, the major symptoms, which are central nervous system, and the symptoms like brain fog, and there are the many other symptoms that initially the group from Miami identified, and that's what caused them to send the patients up to Philadelphia. And then, of course, they had the feud between the two groups as to which is it brain or is it ear? And it's rather remarkable that the group in Philadelphia, which are brain specialists, decides it's the brain, and the group in Miami, that's ear specialists, said it's the ear. How do we explain that?
There are some hypotheses. I don't know if you're familiar with Dr. Giordano's work, who lectures, who explains that because the most plausible hypothesis that has been accepted by both the intelligence community and the National Academy of Science is directed pulse microwave energy. and that is the type of energy that would produce cavitation in the liquids, basically, and this is the
I know about the bubbles in the inner ear theory, but as far as I know, and there's not ever been any clinical syndrome that has been documented to show that, and that we could make a diagnosis of such a syndrome. This is purely hypothetical, as far as I know.
Well, everything is hypothetical, just like mass psychogenic hypothesis is a hypothesis, and
yes.
so direct energy.
But there are many examples of that. There are many, many, many examples of that, but we have absolutely no examples of bubbles in the inner ear causing otolith dysfunction. That's, I mean,
how about decompression disease?
It's not a selective otolith problem. That's not even close. I mean, people with that have a whole range of problems with problems throughout their entire body. And
you asked me for an example.
Well, but example of I'm talking about a selective otolith syndrome. A damage is just the bubbles become in the inner ear that cause damage to the otolith organ selectively.
Well, that's why it's a new syndrome, that for some reason there's a damage to the otolithic organs with cognitive with cognitive symptoms. There's a hypothetical explanation how the cavitation and the shock wave would damage it. If it's a new type of energy that these brains are exposed to, yes, it would be a new syndrome that doesn't remind you of anything that you've seen before. Let's
just take a moment to the other question you raised about the intelligence community has decided that this is due to microwave damage, I guess, to both brain and inner ear. But that's just not correct. The most recent Jason report, which was commissioned by the government, and the CIA actually came out and supported it and presented that. This was the one that was in 2021. It did extensive studies of electromagnetic waves and concluded it extremely unlikely that microwaves could have caused the syndrome. This is the one where they studied a couple of hundred people, more than 300, and decided that all but about 20 could have actual explanations for their symptoms. That was the clinical side. But the Jason reports, there was the first one in 2019 and the one in 2021 were sponsored by the government. These were highly respected scientists in all areas. They included audiologists, specialists in microwaves, certainly in medical specialists, a very impressive team of physicians and scientists got together and concluded that it was extremely unlikely that microwaves could be the cause of this. So I think one has to, the National Academy of Science report is completely different. They did not have the specialists, highly specialized people in the area of microwaves. You look at the composition committee. The chairman of the committee was actually a infectious disease expert from Stanford.
Yeah, he was the leading author, but he had 19 experts at his disposal.
Exactly, but they did not experts like they had with the Jason report. I mean, who were specialists just in microwaves and various other areas. So, listen. I don't have, you're correct. Our hypothesis, but we have the differences versus this inner ear bubbles hypothesis. There are hundreds of examples of mass psychogenic illness with many features identical to this that have occurred in the past. And so there is certainly precedence for that. But I think, as you say, and it's possible there are things we don't know about, always. Yeah, but I don't, we have now gone, since this was first described in late 2016, we have had certainly a lot of people looking in FBI, CIA for weapons, evidence of weapons. What kind of weapons? Nothing. Now we're 6, 7 years going. Not a shred of evidence of such a thing has been identified. Not a shred of evidence.
Well, and yet the most recent intelligence report, the executive summary that has been made public on February 1st of this year, it does name directed pulse microwave energy to be the most plausible hypothesis that explains this injury. And there are 2,000 cases that cannot be explained by other medical conditions or environmental factors, and that's also in the most recent intelligence report. So, how do you square that?
Well, that report was again the same person who was the chair of that was of the National Academy of Science report. Look, there's different opinions by different scientists, but I've yet to see any convincing evidence. I mean, for example, with microwaves, we know there have been examples in the past where microwaves, people have been exposed to microwaves. The clinical picture isn't anything like the clinical picture of these people. One of the prominent, the way microwaves cause damage to the brain is they cook it. It's a temperature effect. And that temperature effect has to get across the skin, through the skull, and into the brain. So to damage the brain without affecting the skin or the external surface, and to cause the kind of damage without showing any effect on MRI or any other objective evidence of damage is, extremely difficult to explain. But in terms of clinical symptoms, in the prior episodes, the first symptom people have is heat. They feel heat. They feel hot. Their temperature goes up. They sweat profusely. This is not the clinical picture of the people who've had this syndrome, the hearing a sound and then having a very variable course of onset of symptoms. It just doesn't fit with what we know about microwave damage and what we would expect from it.
But you're missing the word pulsed, and that's a critical distinction, because short pulses will produce damage without producing the extreme heat. But the energy would produce the shock waves.
What is the evidence for that? What evidence do you have for that?
These are there are animal studies that were published by the Russians. There's some government reports. The difference between just microwave that kind of spreads everywhere and the directed pulsed microwave is the difference between night and day. It produces different results.
But what examples of how it would produce clinical damage to the brain without showing up on MRI or any other imaging technique? If there is such a thing, with the studies you're talking about, they show the effect is it causes it's still the same mechanism. It's just it's more energy when you pulse it in, but it's going to heat. It's going to heat the tissue up more even. So there's going to be essentially damage from the extreme heat inside the brain, and you should see cavitation. You should see signs of tissue damage, and we see no evidence on MRI of any damage to the brain.
Once again, pulsed. That's the difference. It produces the heating up is so small, but it does produce thermoelastic effect. That's what Frey and the Frey effect produces sound. So a sensation of sound, not the actual acoustic sound.
Can I respond to that for a second? You know, in the first Jason report, they actually had audio recordings from 8 of the original 21 or 2. 8 of them actually recorded the sound. 8. That's more than a third of these people, and one actually even recorded audio and video. But the audio recordings, they were analyzed by the scientists that the governments had identified, and after extensive evaluation, first of all, they pointed out, and it's very clear, that these could not be fry effects because you could not record a fry effect, because that is a perception, as you say, and it would not be audible to be recorded. Yet 8 of these said, yes, that's the sound I heard, and they recorded it. Mm-hmm. And when these people were, when the sounds were analyzed, remarkably, they all fit into what would be considered crickets or some kind of an insect sound. So the evidence for the fry effect being the cause of the sound, it just doesn't make sense.
But the cohabitants, people who lived in the same apartment and did not have this effect, if they were really crickets or some kind of acoustic sound, everybody would have heard it. And they didn't. And so that points out to some kind of directed or directable energy that was targeted, that certain people were targeted with it, and not their cohabitants, not their people who lived in the same apartment.
Well, you're now changing the argument that it wasn't like the microwaves; it was some directed sound. So you're suggesting then it was sound, because if they could record it, it had to be sound. It wasn't. If it was recorded, it couldn't be the fry effect, because as you agree, the fry effect is a perceived sound. There's not a sound. It's only right, because it activates the auditory system. Right. So how would they record it?
Right. But you know, the microphone in our devices are not exactly built like our ear. So they respond to electromagnetic pulses as well. So
that is, you're getting off there. That's not correct.
No,
if you record it on they actually could analyze the sound waves. They had sound waves. There was no question they were sound waves, not a microwave. You could run a microwave turn on your audio and put a microwave next to it. It's not going to record anything. I can guarantee you that. So you know, you can't say that, well, it was a microwave, but they were able to record it. That's just not, it doesn't make sense. It either was sound waves, and that was one of the theories. Of course, that was the original theory, that it was actually sound that was carrying the energy, that these people were exposed to maybe sound over a wide range. It was ultra or above and below sound. But that was pretty much dismissed, because most physical experts agree that you could not damage the brain as occurring these people with sound waves. It's just not going to happen.
You're missing. You are talking about microwaves, and I'm talking about pulse microwave. The difference is extremely important.
But you're saying pulse microwaves cause sound waves?
That
they're recorded? No. What did they record then? These people recorded?
Okay. Do you agree that a microphone and our ear perceiving sound differently? One is a piece of electronics, and one is a mechanical sort of triggered by sound waves. The microphone will record sound waves as well, but technically it's a piece of electronic, and so a microphone would react to electromagnetic pulses.
Well, that's not in my experience, or that's not something I would expect. But if you could show that, I would believe it. But I don't understand how microwave pulses would cause a recorded sound. But
because it's a sensor. It doesn't only sense the acoustic wave. By its nature, it's a piece of electronics, and so electronics, you can one of the applications of directed energy is to damage electronic equipment. So my point is,
but the electronic equipment is designed to record sound waves. That's what it's designed to record,
right,
not
but
microwaves, whether they're
right,
pulse
but
or whatever.
it's not doing it like our ear does.
Okay, but I just choose to disagree.
Okay,
Sure, whatever.
yeah, we can absolutely. I understand your position, and you understand mine.
Yes.
This is totally acceptable. I want to go back to the autolytic tests, and the fact that each of the tests might not be reliable, but the fact that they didn't have just one abnormal test, they had at least 2 out of 3. Wouldn't that be wouldn't be indicating that something is really going on with the autolytic function?
Again, I would have to see how the normative data was obtained, who were the normal subjects. You see, this is the big problem. It's not so much whether it's 2 tests, right? But if they use the same normal subjects that weren't representative of this population and would be an effective control, then that's my concern. I mean, and I would really be very happy if we could have a reliable otolith test. This has bugged people in this field for many years, that we just don't have one, and it would be extremely clinically helpful if we did have one. So if they could show that, I mean, clearly the tests that they're using are not something they've invented, or these have been tested and they've been used, and there's been a lot of detailed research on them. And the conclusion is that they're just not reliable enough as a clinical test at this point. That's the point. And because of the normative variability from no response to a large response in perfectly normal people.
Okay, that's why Dr. Hoffer references the normative data. He shows actually normative data, the difference between normative data.
I've not seen, I mean, he didn't certainly publish it in that article, and I've not seen where the normative data, the normal subjects, how the normal subjects were selected, the age range, all of those things. I mean, if that, I think that should be published. I mean, if this would be a remarkable, and I mean, if indeed there was a selective involvement otolith function in this large group of people, and it was absolute, as this would be in Science, the journal Science. This would be published in one of the top journals in the country, because this would be a real dramatic and important finding. But it's not. It's published in a rather obscure journal with, not the kind of peer review that would normally occur with this kind of a thing. That's the truth of the matter. If it were, because it would be such a critically important finding that if you could show that this syndrome is caused and is essentially no or severe otolith dysfunction reliably 100%, that would be really, it would be something that would be immediately recognized as a major breakthrough, and should be, and should be published and so that it can be critically reviewed. That's the key, so that the data is convincing so other people can see it, see all of the facts. If that were the case, I think that's what should be there. If they can do that, then I'll believe it. If they can get it published in a good, strong scientific journal that's going to have adequate and good peer review, I will be the first to congratulate them, because that would really be important.
Are you questioning you're questioning reliability of these tests? Do you think they're not objective, or do you think they're not reproducible? What's
There, as
the role?
I said, there's two of them are totally objective. The vestibular evoked potentials and the subjective vertical is a subjective test.
No. Vertical is objective test because you measure a degree.
No, it's just what we call subjective, meaning because you require on the patient's subjective response to analyze it. But the other two don't require any kind. The patient could be sedated, and you could still do the test. So that's how we usually call an objective versus subjective. It doesn't mean that subjective tests aren't any good. They could be good too. I'm just saying that's the general category. And subjective tests, as a rule, though, tend to be more variable because of the human element of the response. But I don't know that that's relevant because, as I recall, they were putting most of their weight on the objective tests, the evoked potentials as being abnormal.
But subjective vertical is objective because if they measure it in degrees, the patient does not know what position he's in because he's completely in a dark room. There's no.
We're quibbling about a term here, and it's not subjective. Is just that is put in tests can be subjective if they require an individual to make some estimate. That's typically called a subjective test. It doesn't mean it's not accurate, or it has objective features to it in the sense that you measure something, but the point is still the person has to provide a subjective response. But again, I don't understand how that is relevant in the sense that I'm granted they all three of the tests have their positive and negative aspects about them, and the fact that the one requires the person to make a subjective response. That isn't. If it was 100% reliable, no problem with it at all. In fact, there's a subjective response necessary. I'm just saying that all three of them have this same problem of large normal variation and critical importance in terms of the control group, the people that you're using as controls, that they're very well matched with your study group if you're going to make any kind of comparisons. That's my point.
And that's why the criteria for abnormality was very, very high, more than
again, all I ask is if they would publish this in a well peer-reviewed journal showing the normative data, and I guarantee you, if it's on the up and up, that this would be the kind of thing that would be published in one of the top journals in the country. And would be considered a highly important discovery. That's all I'm asking for them to do. Then put this into some kind of publish it in where they're going to get a good review by someone who knows the information and knows about it very well. And if they are accepted and they can publish it and show the data, then I'll be applauding with others.
Yeah, you're kind of putting these requirements. The data is the data. This is what they found. Yes, the control was taken from a 300 people in the population, and the statistical analysis was specifically so strict that it would only catch the really extreme abnormalities. So I understand your criticism. I disagree with some of it, especially the subjectivity of subjective vertical test is just the name. The patient, even he makes a subjective decision, but there's no way he can fake it. Well, wouldn't you agree?
I'm not suggesting anybody's faking anything. That is totally out of it. I believe that people are trying to do their best. It's just when you make a subjective response, though, it requires some processing, subjective processing. It's a different phenomenon. But no, I'm not. By no means You see, this is what one of the problems I've had, and I'm dealing with this from the start. When we suggested this was the potentially mass psychogenic illness, or that some of these cases are, the symptoms are as real with these conditions as they are with a brain tumor. The same brain pathways are affected. These are real symptoms. So people aren't faking this. These are not weak people. These are people are like everybody else. It can happen to anybody. And I think we still have this misconception by physicians and certainly by many in the general public, that how could this happen to an embassy employee? These are high level people. Indeed they are, and they're not making this up. They're not faking it. They have symptoms. The issue is, what's the cause of the symptoms? And if you think they were caused by a brain injury from some weapon, that can be actually detrimental to their future health and their future well-being.
Right.
So that's all but don't suggest that I think that anybody's faking the tests or how they're doing. I think though one has to be critical of reports, and that's why we have this scientific. That's what science is. Science is a process. It's not a single report. We know that probably 70 to 80% of scientific publications are wrong and misleading. That's the science process. So requires that people let their ideas out. They provide the data and let the scientific community repeat it, try to repeat it, show that it works or not. But to say just because one group found something that we have to accept it, I want to see the data. I want to see more information. I think what was published so far just isn't adequate for me. But if they do publish and show, if this is a uniform 100% in all patients, they should be able to get 100 people with this abnormality and show it and demonstrate it and effectively use control data. It should be published. As I said, it would be a remarkable finding. People in the scientific community would be overwhelmed. It would be in Science, really, which is the top scientific journal in the United States, or Nature in journal Nature, one of the top. So I think we need to just be. I'm not making any final judgment, but at this point I'm very skeptical of that finding for the reasons I gave you.
I'm very skeptical of everything. This is why we're having this conversation. I'm skeptical of mass psychogenic hypothesis. I'm skeptical of directed energy hypothesis, as one should be. But it's been called the most plausible cause for a reason. National Academy of Sciences commented on your hypothesis as unlikely, and said that even a mass psychogenic hypothesis requires evidence, and there was no really scientific methodology behind this hypothesis. It's a guess, and if there's data that falsifies it, then we should abandon this hypothesis.
Obviously that's the way science works. If you have evidence that makes it false or makes it highly unlikely. But I think that's the same what I'm saying about the theory of bubbles in the inner ear from some kind of directed energy source causing selective otolith damage. Just, if you provide the data that will support that hypothesis, and I've not seen it, I would buy it. I'm certainly not fixed on any hypothesis in this. I've been open right from the beginning, but I'm
very
suggesting that I really just don't at this point. I can't buy into that because of the absence of, I think, convincing data.
I understand your position. But we do agree that these are objective tests. From your perspective, at least, the both of the VAMP tests are objective.
Oh yes, no, I mean, as I say, that's the definition of it. There's no actually human, you know, response required. It's a reflex response. Now that, of course, is a weakness in itself, in that we're not testing the otoliths, we're testing a reflex that otoliths are involved in. So anything along that pathway, including the muscle,
it could be damage to the nerve. It could be damage
or
to
the muscle is not adequate, or any. I mean, and that's why I think, and that's what with most people, but why the normative data is so variable, because all of the possible factors that could explain altered responses, including simply aging. That's well known.
Okay. Do you have questions for me? I mean, I really appreciate you.
No, I enjoyed that. I think it's this kind of discussion is important, and people need to be open and address it. And this is very often when I've been involved in these types of things. You know, I'm asked one or two questions, and then the other people, the other ideas, there's not any actual discussion of some points where maybe 2 points of view are bounced off each other, and people have a chance to do this type of critical questioning. So that's what's needed in this, is but not like, you know, 60 minutes interviews where there's mostly testimonials, and you know, as we do nowadays, making our news is it got to be more some human interest. It's hard to do this kind of thing. Now, obviously, I really are concerned, and I have compassion for these people, because they have real symptoms and their lives are being damaged and affected. And I think that it's important that we keep that in mind. So that, and I do.
So you think they do have damage?
No, I think they have symptoms. I don't think they have brain damage. That's a big difference, because because I think that is dangerous, and we know from prior similar kinds of events, if people think they have brain damage and are told they have brain damage, they're much less likely to get better. It's just the way our brain works. Brains set up that.
Well, thank you, Dr. Baloh. I appreciate your time and your willingness to discuss these complicated topics.
Good luck with your podcast, and I enjoyed talking to you.
Enjoy as well.
Bye-bye.
Thank you.